Hello everyone, this is Amrita Patil Pimpale from Echoing Healthy Aging. Today with me, I have Dr. Niti Sapru. She is a senior psychiatrist from Holy Family Hospital, Bandra, Mumbai. She is also regularly guiding the dementia caregiver support group started by Dr. Charles Pinto from Holy Family Hospital. After he passed away, Dr. Sapru has been giving her invaluable advice and guidance to our support group members. Today, we are here as this is 21st September, the World Alzheimer's Day. And this year's theme is No Dementia, No Alzheimer's. So I in fact have Dr. Sapru to guide us about on this disease, about diagnosis of it, and also the management part of this disease as well. So welcome, ma'am. Very nice to have you. So, ma'am, the first very basic question is, what is dementia?
Thank you, Ms.Amrita. And I think a World Alzheimer's Day was quite the need, seeing the number of people that are growing old, and very likely to land up with some of the other faculty failing them. So, dementia is a slow brain death. The brain cells, the connections, the synapses, the areas where the neurotransmitters and the signals go across from one cell to the next, they die out gradually. And normally it starts, say, by the age of 60, 65, and we start seeing patients after 65 years of age. A small number of patients also manifest them earlier, before the age of even 50. More so here, I would like to say, we are seeing the increasing lifespan of patients with Down syndrome. It's a kind of an intellectual disability. So they, when they survive around 45, 50, they start showing signs and symptoms of dementia. So it is a term. It is not a diagnostic code per se. It is like a syndrome under which number of symptoms come, and the number of diseases can give rise to the same kind of symptoms. So dementia is something that is, there are two kinds first at the beginning. One will be the kind that is irreversible, and there's an irreversible dementia. So I am going to address currently the irreversible one, because it's the Alzheimer's Day also. So it is whereby there's a gradual insidious onset. Person starts losing, so to say, the sheen of what they were before, and many times it shows up as small memory glitches. So they forget certain important things, they forget appointments, where they've kept their glasses or something repeatedly, not once in a while, and they act as though somebody's taken it away, or God knows what's happened to them, and they start blaming the other person. They get into a panic reaction, and there is no cue that makes them remember it. So like, say for example, somebody is getting up to take a glass of water from the kitchen. If this is a patient who is not of dementia, or rather not a patient, it's normal aging, and the doorbell rings, and there's somebody at the door, and you are asked 3, 4, 5 questions at that time, like they have given a, what can I say, it's a courier, so they're asking the name, they're asking for your password that they have given, they're asking you to show document, the number, and all that stuff. And by the time you're done with it, you may forget, because the working memory, the memory that keeps the necessary work in the mind that is required to do day-to-day activities or moment to moment, that can accommodate only a certain number of items in it. And you come back, sit down, and suddenly when you feel thirsty back in the same chair, you start thinking, oh, I had got up for it. That would be like a normal aging kind of a thing. Whereas somebody with dementia would totally forget, come back and continue, and do other things. There is no memory link, so to say. Now often that's not the only one. We also get non-memory cognitive impairment. So there is an impairment in all the processes that are required. Cognition would also include memory, learning, being able to accomplish various tasks, and for those tasks we need to be able to put something on hold. We need to be able to plan, to execute that task, to organize in a particular way, to recognize things, to have a fairly good idea about where to go, how to do things, the visuospatial aspect, all of them together. So inhibiting some particular impulse, planning in advance, being able to execute it properly, all the initiative itself to start doing something, these all get affected gradually. Often memory is the first one, but not almost always. Sometimes they can just come with, they've just lost their way around. They cannot recognize familiar things. They may start doing transactions which are very different, inviting person who they don't know well inside the house, or start giving personal information to somebody who has just they met on the road and stuff like that. So you see that there is the indiscretion happening, the judgment gets affected, and that's how it starts showing up, and gradually there is a downhill progress in almost all these parameters. So technically, till we do not see a dysfunction in at least two or more such cognitive domains accompanied by an impact in day-to-day activities. So it should affect the day-to-day activities of a person, and then we would clinically make a diagnosis of dementia. So like I said, it's a term under which many such subtypes come in. Alzheimer's accounting for almost 60% of all kinds of dementias. In India particularly, we also get the mixed variety of dementias often because of the cardiovascular factors, the poor health of the arteries, vessels. So all these get compounded by diabetes and hypertension. So that we get also a mixed dementia. So so that is the way it progresses. By the time they come to us, by the time we're able to make a reasonable diagnosis, they are quite late, so to say, in the progress of the disease. Okay, I'm not talking the staging of the disease, but so to say from the onset. So before we see them, much before that, almost 10 to 15 years before that, the brain changes are happening. And we see them, we pick them up. And if it's the memory one, they come earlier, others may be a little late. So that is how it presents itself. And Alzheimer's is definitely, and other forms of dementia that are not reversible are terminal, because they progress into a stage where almost all functions of the body gradually die down and the brain cells die. So the final pathway is death for patients of dementia, which I think we all do know about it, and very painful to see a person go through that, the relatives. What is it that you would like to know now? How do we diagnose it?
Yeah, actually, what you have mentioned, all these symptoms, very important because most of the time everyone associates only memory loss to
Yeah.
dementia. So very interesting to see others and know about other symptoms and how someone can try to catch it early on and try to get the diagnosis. So, ma'am, you also mentioned that since this is incurable and progressive disease, caregivers, in fact, do suffer during this journey of caregiving in that sense, not just the person with dementia.
Yeah,
So would
I
you like
think
to, in fact, give them some tips or, usually now everyone does talk about empathetic care. So how does that look like when it comes to caregivers and person with dementia?
I think empathetic care is what we should have in all forms of care, not just dementia per se. Having empathy and understanding what the person actually is feeling is one of the hallmarks of giving good care. And like you said, this group is for the carers of patients with dementia. So we are addressing them primarily. And by the time they join us, they have some idea about what dementia is. Many of them are reading up, it's there on the net. Also, we see that there is a small section that lives in denial. They find it difficult to accept the diagnosis, and they try to come up with some of the other explanations, like oh, they went through a big loss, oh, इनको बहुत झटका लगा, something happened, and maybe they were not very up to it when the doctor tested them, or maybe something else. So this is like even after the MRIs and the brain scans may show something, but yet they have this wish to see their loved ones okay, like which happens with almost all chronic illnesses. Denial is a very important step. So they need to ask those questions, they need to be told those answers, they need to be advised that if possible join a group like a carers group, where they can bounce off these things. They have seen other people been through that journey, so they can also address what their reactions were when the diagnosis was given. And then begins the difficult part, so to say, and the sad part for the caregiver to care for somebody who was always somebody they looked up to, somebody who taught them all the very basics of life, which now they've got to walk the path with towards the end of their lives. In many ways it's similar to caregiving for a child, taking care of a child rather, but it's not the same. because the child is growing by leaps and bounds, whereas here there is a loss of the abilities as the days go by. So often they have language difficulties, so they're not able to understand the complexities of language. But in the initial phases, they can have a very superficial language. So if you meet them in functions, you see them, they could be able to hold some kind of chit chat. How are you? I'm fine. How are you? And you're that way. And somebody will say, oh, they're all right. But little more, and you have more discussion than depth, and they are not there. So in the initial phases, they're aware of their deficiency. Some just keep quiet when they realize they made a mistake, and some get very angry if they're reminded, because they're aware they're doing something which may not be up to the mark. And then if you say things like, it's all right, don't worry, they don't like it. They think it's babying them or like making fun of them, and we could get an anger or a withdrawn reaction from them. And then as the thing progresses, language becomes more and more difficult. But the non-dominant hemisphere has rhythm in it. Okay, so the rhythm is there, music is there in that. So what happens is that they keep on blabbering, they keep on talking, and like I had seen, but talking not in meaningful communication, but they keep on producing some kind of sound. So like for an example, I had seen a patient with Alzheimer's, and she was smiling, maintained the countenance. There was no eye to eye contact, so to say. But she went around the examining room and so it was a continuous outpouring, no content, no communication, so to say, no relation. So this happens because the rhythm stays intact. So sometimes, because the rhythm also stays intact and because disinhibition happens, they tend to utter things in the initial stages when speech is still relatively intact, inappropriate words. So like, they can have some kind of communal comments, they can have skin based comments, they can use the words which are not to be used publicly, and they don't realize it. So if they're angry, they would not be able to say, why have you said this? So they may just say, shut up, you big thing, instead of, that's the only 2 or 3 words that they remember. So if they want to compliment you with something, they may just start, oh, you're looking very nice, and then land up with some really inappropriate comment because they don't have the vocabulary that much, but they still would like to talk and the rhythm is there. So people can't understand. Their relatives, they get ashamed that why has my mom or why has my dad or why has so and so done this, and other relatives, and something has gone wrong. How can they be like this? We see is actually inappropriate behavior sometimes. They're not able to understand because there is a disinhibition. So as it progresses, it's very difficult to see. So in the past, they were doing what was called as a reality orientation therapy. Means like the person says, like, oh, somebody has stolen my stuff, I can't see it here. Very often they say that my medicines are not there, somebody has taken my jewelry, and you can see it there, but you're not going to say straight away, no, why are you saying that? It's not like that, mom. So instead, you accept and say, oh, let me look into it and see what I can find out. What exactly went? So you're actually talking to them, you're validating, so they don't feel like they're not being heard. It's very tough, I know, we have to inculcate that. Also because the person who's giving care very often is a family member. And there's a pattern already set prior to the illness came in of communicating. So suddenly to break that pattern, one is not aware. One is also emotionally burdened with the thought of seeing, one's own person gradually going away, losing, and maybe if they've had in the past another family member, it only adds up to the anxiety of like somebody dealing with a terminal illness. You feel alone, you feel unsupported at times, you feel tired, you're doing many things. So these are very natural reactions to get angry, sometimes disappointed. Guilt is so common because they think they have not done enough, they are not doing enough. It's very difficult. Ideally, the olden days staying together was good because there were at least 2 or 3 members who could take turns, who the patient was seeing almost every day, and they could give the care. Now it's very difficult. As they start realizing that their hold is going, some of them start shadowing one relative that they really feel most dependent on. What they do is they don't let the person even go to the bathroom or use even the washroom. The outside they'll keep on banging, and they want the person all the time in front of them, and they keep
Yeah,
the
so true.
person. Yeah, so it makes it very difficult for the caregiver. It's extremely exhausting with all the good intentions. This is very important for all the caregivers to understand. that guilt is the last thing you should be entertaining. Okay, helplessness, hopelessness, talk to people, access groups, get more knowledge, understand that you can or anybody else can do only this much. Reality orientation doesn't help. Validation, try to keep their surroundings as less messy as possible with very little stuff around them. Keep it simple, keep it basic. If you're for some reason having a party at home or there's going to be loud noise expected, inform them beforehand. See that they can be moved to a place where there's less stimulation. Okay, yeah, so then they don't overreact. So the meltdowns can happen with anything, as simple as you've just gone and touched your parent, so how are you doing, they suddenly react to the reaction as though, the alarm reaction, and they wonder who this person is, who are you, where have you come from, because in that moment they do not recognize you. Or if you're around and you say hi mom or hi dad, hi baba, whatever you want, like the various ways of talking are, कौन है तू, and you say I'm your son. No, you're not my son, because at that time the memory is gone back when you're younger. My son is not that old. So, and then you do not know how to react. So, there could be things like, yeah, mom, just by magic I became. I know I was that young. So instead of saying, oh, here I am, what I am, because that aggravates. You can have problems like we've been discussing in groups, if you remember. People have issues about eating. So, try to find out what is easy for them. Now, because of dyspraxia, apraxia, that means disability to carry out an action, a voluntary action, they cannot even initiate. So, if they want to do something, they're sitting there because they do not know how to start it. The very initiation of the whole action is gone. So, you may come back in the room 2 hours later and say, Arey, abhi tak nahi hoga, you've still not finished this, you've not, and they have not even begun. Yes, I'm going to start, yes. Or they'll empty out all the contents of the cupboard or of the drawer and they do not know what to do, because the initiation is a problem. And you sometimes, as a caregiver, depending on also the relationship you've had, depending on the personality thing, oh, they're trying to trouble me, or she's trying to trouble me, I'm tired and this is what I get at the end of the day when I come home, or he's trying to do this, they just don't understand me. They cannot understand you. They cannot understand what's happening to their own selves.
True.
As they lose all the faculties, one thing that remains is their ability to feel emotions like even love. See the disgust on the face, see the uninvolvement, or the anger on the face of the caregiver that they register. So behind all that, in that disease, in that particular body, in that relation with you, is still that person, the person that's lost, extremely scared. Can you imagine roaming around in a house thinking that your house is not your own house? Thinking that there are strangers in your house, somebody's trying to break into your room.
Extremely scary. Yeah.
It is extremely scary for me also. If I stay alone in the night, that's the first thing I want to ensure, that my house is safe.
Yeah.
So any kind of sound that you get, you tend to look up, because our cognitive faculties are intact. We can make sense of what's happening. But the moment it is not, we start worrying and you get a panic reaction to them. So that it is difficult to initiate them, to understand. You have to inform them. Very importantly, whatever has to be told to them, if you can make an attempt to do practice, always look at the eye level of the patient. So don't talk down to them. Come to the eye level. Speak in a calm voice. Give one command at a time. Do not jumble up too many things, as may have been the habit you all talk. Maybe this person could talk very fast. Maybe this person could say many things, could multitask, but now they can't. And you're also tired. So it's imperative that you look after yourself. It's very important that caregivers look after themselves.
Wow, really good pointers. And I think in just last 5-10 minutes, you have given us really good tips that we have to step into the shoes of person who has dementia, getting their point of view, understanding what they are going through. And that's when we will we can provide them empathetic care. So quite wonderful, ma'am, to in fact understand their point of view. Very few actually talk about these things. So we call it BPSDs, right? These behavioral symptoms, how to handle them, which to an extent is part and parcel of dementia, how to handle communication, and overall also from post diagnosis, what should be the caregivers point of view, and also training themselves, right, empowering themselves through these training support
Empowering is
groups.
so important.
Yeah,
They need to have de-stress techniques.
yeah.
So, like I said, if you can have one more person who can be a caregiver, you take your time off. However much you think they cannot do without you, you take your time off. Don't feel guilty. If you can take a 1 or 2 break or a holiday, if it allows you with the other person accommodating, please take that without the guilt. It's something like when you have a child and you take the 1 or 2 holidays first without the child. All the time on the holiday, you're not comfortable, you're thinking about the child, you're guilty, thinking, am I a good mother or a good father? My child may be at home and we are taking a holiday. It's something like that. But it's very important that the caregiver here has to. They found in a study that the levels of stress is very high in the caregivers of patients with dementia, and simple technique of breathing, remembering to breathe deeply. So it's an abdominal breath. So even if you take say 5 breaths, 3 times a day, they have done it for 3 breaths 5 times a day, but sometimes we forget to technically set a reminder on your mobiles that breathe. And how do you breathe? You take a full deep breath inside and then you release it only through your mouth, like slow. Okay, you need to practice. So, and you feel the abdomen coming out and the abdomen going in. So that's the diaphragmatic breathing. It stimulates the vagus nerve, which again stimulates the relaxation response. And they have found by doing this diligently over a period of, in some studies 8 weeks, over a period in some studies 6 months, depending on the frequency, they have found that the raised cortisol levels have come back to normal. It's such a simple technique.
So impressive, and such an easy technique.
Such an easy
Yeah.
technique. We all need to breathe, right? Also, when you're approaching your loved one and you are highly strung, you have your own life also, right? You have your own reasons also. You may not be well, you may have work pressure, family pressure. If you can just take 2 of these quick breaths, it immediately lowers your response. And often what we do is we mirror what we see in the other person. So if you look tired, if you look caught up, if you look irritable, your loved one also is going to pick up that, and their levels of reaction already will be quite high. So also seeing you on a calmer note by just doing this simple technique. So if you're entering from one room to the other, you could just take these 3 breaths and approach your person. It automatically will reduce the chances of having a high negative interaction.
Okay, so very interesting that I like the idea of putting an alarm, because every day when we are caring for someone, managing our own commitments, so when we have that alarm going off, we know we have to do this.
Yes,
So very important, I think, message here, that you have to care for yourself
yes,
first before you are offering care to someone else, especially your loved one. And there is nothing wrong in that, no need to feel guilty.
right.
So quite wonderful techniques, ma'am, and a good message and tips as well. I thank you for your time.
Can I just
And
add two
sure,
minutes?
sure, sure.
That for the patients and for the caregivers, exercise is important.
Right, yeah,
Sleep becomes a big problem as they go along the illness.
yeah.
So, for that, whenever the patient gets up in the morning, please ensure that if it's easily possible, keep the patient in the balcony, let them get the morning light in the eyes, so to say, not direct sun, sunlight, light that stimulates many hormones and that help regulate the sleep. Similarly, 4 o'clock, 5 o'clock in the evening, if they can go out, that'll be best. If later on they can't go out, they can at least get to see bright light. It helps in their sleep cycle. Light also is used as therapy for sleep in some places. And if we can do these things, exercise, make them feel useful, productive. Even simple thing as still they can work, just peeling the peas. So they feel good about it. Give them the feedback. Or like there was a patient who was like feeling what to do, and the doctor said, "Mom, let's get back to the kitchen. Let's do some crochet." They may not complete it, but it's just the feedback that you give them that makes them feel worthy. Like I said, they are sensitive to what's happening on your face, so they can pick up that look of appreciation. They can pick up that look of love, or wonder, wow, she did this or he did this. So small small things like this. uh, and of course, likewise, the caregiver also has to have exercise, because there is a risk of developing dementia, because you have somebody with dementia, all the more when the stress levels are high. So exercise, healthy cardiovascular health, diet. So I have not touched on them as an irreversible causes also sometimes, but they
Right, but I
also
think we can definitely do a series on that. That also does sound like very interesting topic.
but that's also contributory factors to
Right,
development of Alzheimer's, and they're
right.
also some of the preventive factors. So you can prevent the onset, or the
Very
delay it, or
important.
maybe just avoid it. So everything is not genes, everything is not environment, but it's a mix.
That's actually good to hear that because everyone is worried about getting Alzheimer's these days as we are growing older, right?
Yeah, yeah,
So yeah, I mean, good to know that there are certain factors that we can manage on our own, like lifestyle factors, especially for caregivers,
true,
managing their stress, right? Exercising.
true. Cardiovascular health, that there are lots. So I think this is not the scope
Yeah,
that
no,
we
but
have.
I think definitely we can have one more video in the series on those topics.
Sure.
Ma'am, thank you so much for really
My
good
pleasure. Thank
tips.
you so much.
Uh, and we look forward to having you for our other support group sessions, guiding
Okay.
our caregivers. They always
I
look
too.
forward to your sessions.
Thank you so
Thank
much.
you very much. And uh, today is the World Alzheimer's Day. I think this day is also very important to create awareness about the disease.
Yeah.
So yeah, I think it's very important to know these symptoms, diagnosis process, and especially if you have any people around you who have dementia, you must look out for them, and also you must look after their caregivers as well. They also
True.
need support.
Very, very important, the caregivers. Like, almost always you hear in all the groups or somebody talking about caregivers. Like when you're on the flight, they say when you use the mask, even if you got a child with you, you
You
use
must
the
wear it
mask
first,
first
right?
and then you put it on the child. So it's the same thing. Anybody that's extending care has to look after themselves to give good quality care.
Really, really good tips, ma'am. Thank you so much for your time,
Thank
and
you. My
thank you
pleasure.
everyone for listening in.
Thank you for calling me and inviting me. Thank you.
Our
All the
pleasure.
best. See you next month in the careers
Sure.
meeting.
Yeah.